So, good morning, everyone. My name is Albert Alonso. I am a senior researcher in a hospital clinic based in Barcelona, and I will have the privilege to chair this session this morning. Just to make sure that you are in the right session, this is session 6L, and the name is it's care coordination, and it's being live streamed, and therefore I have just asked all the presenters, 6 presenters this morning, to sit here on the couch, but also we will be getting questions from the virtual platform. Now, I just want to make sure that everything will be as smooth as possible, and the thing that I have decided is just to allocate 12 minutes for each of the presenters, followed by 3 minutes of questions, and then I will invite questions from the audience, and also we will take any questions coming from the virtual platforms. So without further ado, we will start by our first speaker. She is Karen Fredrix. She's a policymaker from the Flemish Agency for Care and Health. The title of her paper is Towards More Health-Oriented Care Through Care Coordination and Care Planning. And this paper sits in the context of the reform that is taking place in primary care here in Flanders. So, Karen, the floor is yours.
Hello, everybody. I would like to invite a colleague of mine, Patricia Chavez. She's working for the Federal Public Health Service, and we are going to do this presentation together. So Patricia will start.
Okay. Thank you very much for inviting us to this presentation, and thank you for attending this presentation. So my name is Patricia Chavez. I work for the Federal Public Services of Public Health, which belongs to the federal government. I would like to start with a little bit of context before Karen explains you the concepts where we are working in. Why did we choose to work together? Because the context here in Belgium is quite complicated. That happens also in other countries, but in our country is as you may see, so we have the federal authority, we have the regions, the communities, and each of these different entities have their own competences and responsibilities. So for 11 million people, we have 8 ministers of health that have to come together in an interministerial conference to make decisions together in order to implement healthcare. So just very quickly, many things that you will maybe know about our characteristics of our health system is that we have a very good health system in Belgium that covers more than 99% of the population, where the main source of financing is contributions that are proportional to the income of the people. So it means that people give, as they have more, they will give more contributions. And so the other characteristics you may see that I'm not going to give all the details there, but which is important is that we have also on the top of the political agenda many actions that are based on the quintuple aim. And that's why many of the measures that we are promoting are oriented to stimulate integrated care, multidisciplinary work, care coordination, and so on. So something that is also really important is that we have many different in policy among the regions. That's how since 2014, where we have a sixth reform of the state, there were some competencies that were transferred from the federal government to the federal entities with the objective of redesign the landscape of hospital care, and also to regulate and to change, modernize the work of the health professionals. And that's how in Flanders they already work very hard for their structuring their primary health care. And they have the 60 different zones, and while in Wallonia and in Brussels, they are still working on this structuring. They are currently working on this structuration, so it's really a work in progress. So as you may see, there is different speed on these things. So what about the plan? In 2015, there was already an integrated care plan that was oriented to the chronically ill person. And we were working in the implementation of pilot projects that ended in 2022. At this moment, we saw the opportunity and the need to work again in this integrated care plan. So that's why the federal government hired a consortium of consultants to work us to prepare and to elaborate this integrated care interfederal plan. And we've been working since that very hard in many consultations with different stakeholders, where we try to make up the framework of what is going to be inside this interfederal plan. So as you may see, among this process where we consult and gather with many stakeholders, we already identify 13 topics where we are working, and we have to start somewhere. So you see here one of the topics is care coordination, care process, and case management. So Karen is going to explain to you a little bit more what about these concepts on the interfederal plan we are working in.
Thank you, Patricia. I will move to the next slide. The thinking about care coordination, case management is following also. That's not a new thing. Patricia also said we are talking about it since 2014. And in Flanders, in our region, we have had a big conference in 2017. And there we started with the reform of the primary care in Flanders, and the thinking of integrated care, integral care, care coordination, case management started already there. So since 2017, we are negotiating, discussing all those topics, and what I'm presenting here is what we are discussing for the moment. And what characteristics care coordination and case management have for us today. For us, in the case of care coordination, the starting point always is that the person himself does the coordination. For us in person-centered care, it has to be that the person himself is in the center of his care, in his care and support, and that he should be made able, supported to do his own coordination of his care process. Only if in the case or if he doesn't desire to do so, or he is not in the possibility to do so, then we can shift to the informal care providers, or on the other hand, the professional care providers. The characteristics of care coordination at this point are the one that I show here. Care coordination is always done by someone of the care team. The care team is a very important topic for us, because in the case of integrated care, in the case of integral care, we always think in a team logic. When you start from the needs, but the desires, the goals of the person himself, you can't give care and support that is given by one care provider alone. So you always have an interdisciplinary approach to do, and always see that the person is a part of that care team, because he is owner of his goals and he has to take part in realizing those goals. So the care team is always a cooperation between the person himself, informal care providers, if they are so, and the professional care providers. So in this care team, the care coordination takes place. It's a role within the care team. In the first place, as I already said, the person is in the lead for the coordination. In the other case, if not desired, or he is not in a possibility, then you can look at the informal or a professional care provider. Care coordination, it hasn't always has a start at the beginning of the care process. It can be an evolution that you find it necessary to have care coordination. You can start without it when you have a very stable, a very not too complex care situation, but when you're shifting towards more complexity, to instability, it could be possible that you are shifting also to care coordination because of the complexity. You have a lot of care providers that work together in the care team, and someone has to manage all the goals and has to manage all the actions that the care providers take. So you have the care coordination when it's in place along the whole process of the care process. For us, care coordination is the overview of all a person's care and support. And it's also based, ideally, on life goals. It was already mentioned yesterday, on the care and support goals and a care and support plan. Case management, it's another topic we are discussing on. For us, care coordination is what you should really have in a complex situation. Case management is for us an extraordinary thing you can put in place when things are not going very well. You can see it on the picture. You have the care team, you have the person in the center, but there are disruptions in the process, and it could be possible that you could use some support to have a better care process. So for us, case management for now is something that is limited in time, and it is very important. It's a support for the care team to enhance the care process. You have, on the other hand, when there is a care team, then you can have case management to optimize or to improve the care process that is already existing. On the other hand, case management can also be interesting for a person who has a lot of needs, but doesn't really get to his care and support. Nobody takes it in hand, or he refuses it. Then case management can be interesting to establish a care process. So what's very important, because it is a support to the care team, case management is done by someone outside the care team, someone that is not giving the care and support to the person. It has to be someone that is neutral, objective in a way, to look at the care process and to look where the enhancement can be made. And case management never replaces the care coordination when there is care coordination in the care team. Something that is important to mention, Patricia already said it, in the interfederal plan, there are a lot of things that are in care pathways. You have obesity, for example, or the care for pregnant women, COPD, there are a lot of things. So the vision of Flanders is what I show here. Care pathways are for us a pre-designed scenario about the course of the care and a cure for a specific pathology. So it's a very vertical situation. A person can have a lot of pathways, but when we look at it from a Flanders point of view, and you look at it in an integrated care and support way. It could be that the person, besides the care pathways, has other needs, has other goals. So for those needs and goals, you also have care and support. That are all vertical situations. And for us, the care coordination has the overview, has to put the strings together to establish a coordinated care process. This is the drawing that we made to visualize the vertical situation of the care pathways and the coordination that puts us all together in a more horizontal way. So, thank you very much.
So, any question for the audience? No? Any question virtually, Nif? No? So I have a couple of questions for you. You have been describing differences between case management and care coordination. This is, to me, a little bit unusual, specifically in the context that you have described that. Is any specific reason for that?
Why there is a...
Yeah, please, you should talk to them.
Sorry. I didn't understand the question very well. Why there is a difference between care coordination and case management?
Because usually in integrated care, we tend to merge case management as a tool within care coordination. But you have very explicitly described that as a different type of activities being done by different people. Therefore, what I am asking you is, what's the reason behind that?
Yeah. For us, care coordination is what you should commonly have in a complex situation. But sometimes I described two situations when the person is not getting to his care process. Then you have a case manager that comes beside the person to look at his needs and his goals and to establish a care process, and then also form a care team and give, when necessary, the coordination to someone of the care team, and the case manager steps aside so the care process can go on. Case managers for us is something that we hope is not always and not too often necessary. Because we believe that the person that takes care coordination as a role in the care team should have enough competencies to do a very good job in care coordination, and that he can solve problems, crisis situations or acute things himself without needing the case manager. But in some situations, and we believe in the situation that we go from care coordination that is not in our vision established, and a fully established care coordination situation, that we will need case management more or less.
Understood.
Can I add something, please?
Very shortly.
I think that it's very important that you also put a framework in these concepts. And I think maybe, as Karen described, you can see that there are different things that may be done by different persons. But in other contexts, that can be that it's one person that makes the full job. So I think that is the vision of Flanders, but that is, there is also other ways where case management can be implemented, and it is important that we put this in a framework to make us to know, okay, this is the concept, that is the jobs, that is linked to this, and so everybody knows what we are talking about when we talk about care coordination and case management.
Excellent. Let me just take, it seems to be, there are a couple of questions being done virtually. The first one is, how should coordination of care be financed? That is the first question. Second question is, you state that case management never replaces care coordination. Could you please elaborate? Could you please elaborate? Do you mean a kind of facilitator, consultant in coordination? Perhaps if you can focus on the first one, right, in the one that refers to whether should coordination of care be financed, that would be fine, because my question was already in the same direction of whether, there is this overlap between case management and care coordination. So for my good understanding, when is care coordination really necessary? That's the question. How it would be financed?
Financed.
Finance, yeah.
Okay. That's a question that we are all still talking about, because that's why this interfederal plan is so important, because the competences from the federal government and the regional governments are a bit shattered at this moment. So we are talking about how we can finance it, but we can't give any answers for the moment.
No. Thank you again, and we need to move to our next speaker. So our next speaker is Jorid Kalseth she's senior researcher from SINTEF Digital. Her talk is about implementing national care coordination guidelines for people with complex care needs, evidence from a pilot study. And basically, as I understand it, it's a study that uses qualitative approach with mixed methods, right? The floor is yours, Jorid. You have 12 minutes. This to advance the slides.
The green one, okay, thank you. Yes, I'm going to talk about a pilot study in Norway where the aim is to implement national care coordination guidelines for people with complex care needs. And the pilot project is called Structured Interdisciplinary Follow-up Teams. So the new guidelines were issued by the Norwegian Directorate of Health in 2017. And people with complex and comprehensive care needs is defined as people that are typically in need of follow-up in many areas of life and across professional disciplines and sectors, and not just the health sectors, but also non-health sectors such as social sector, welfare, education, labor, etc. So the guidelines are generic. They cut across professional disciplines and organizations, diagnosis, age groups, etc. In Norway, the municipalities are responsible for providing primary care, long-term care, education, social care, welfare care, nearly all types of services except for hospital care and specialist care. So these guidelines are mainly targeting leaders at all levels in the municipalities. So the key elements of the guideline, and this is, I can guess, some resonance to what you talked about. The key elements is for the municipalities to establish system and routines for early identification of high risk for developing complex care needs, to have a systematic and interdisciplinary assessment of care needs that covers the different areas of life. If needed, to have a follow-up by a dynamic, small interdisciplinary care team, which is called a follow-up team, which is led by a care coordinator. And as you talked about, so this care coordinator is one of the members of the team. And the team is the helpers, the other helpers or informal carers. And in the center is the user itself. So the fourth element is person-centeredness or user involvement and taking a goal-oriented approach, follow-up approach, asking what matters to you. And using an individual care plan. In the care plan, you set the goals, the tasks, the roles, the responsibilities, and evaluation of progress should be done as a part of the individual care plan. And individual care plan and care coordinator are patient rights that are already established before the pilot. So it's nothing new in Norway. The individual care plan was introduced in 2001. So the pilot project is to implement these guidelines in 6 municipalities in Norway. And the pilot period was originally from the autumn of 2018 until 2021, but has now been extended for 2 years, so it's still going on. And the pilot municipalities, they receive financial support and process support to implement the guidelines from the project owner, which is the Norwegian Directorate of Health. So SINTEF, my organization, evaluates this implementation of the guidelines in these 6 municipalities, and I'm going to present some few findings from the first 3 years of the pilot. And we've done a mixed method, longitudinal multi-site case study approach with a lot of interviews as well as survey data among managers, care coordinators, municipal employees, as well as interviews with the users. So there were already care coordinators in before the pilot, since this is a patient right, you know? So we discussed the findings in light of implementation theory, pointing on 3 main determinants of successful implementation, that is characteristics of the intervention itself, of the setting and the context, and of the implementation process. So main findings can be summarized as follows. The implementation has taken considerable longer time than was originally envisioned. The main focus on the 3 first years was on getting necessary structures and system in place, and the municipalities have progressed very differently using different approaches. So why was this? Okay, looking at the intervention factors, this is a very complex intervention. It has a lot of measures at different levels of the municipality, from top management down to the user, and cuts across many sectors and a very diverse target group. So you can expect it will take time. As well as the knowledge and motivation in the services varied. For instance, especially in the non-health sectors, they didn't know about the guidelines, they didn't think that it was relevant for them, they had other purposes. And also, some of the elements are already in use. You have individual care plan, you have individual care or care coordinator, you have teamwork. So some felt that they couldn't separate this from existing practice. Is this the emperor's new clothes? And also, adding to the confusion, is there a lot of coordination mechanisms in use and related concepts? For instance, cancer coordinator, specific coordinators. So this is kind of confusing. So this doesn't help for this implementing these guidelines. The municipalities had very different starting points, which has influenced their progress and the step taken. Motivation for participating was very different. The existing routines and structure in place are very different, especially in relating to what in Norway is called the coordination unit. In all municipalities are supposed to have a coordinating unit, which is overall responsible for ensuring that people in need get the individual care plan, care coordinator, and a care team. And they also sometimes go in and do a type of case management, if there are very complex needs. So some had a very good organization of this coordinating unit, some had none. They didn't have this unit, so it's very different. And also the pre-pilot quality of follow-up varied, not just between municipalities, but also within municipalities, between user groups and sectors. So this added also to the delay of the implementation. And there was also, the pilot had to compete attention, time, and resources with the other thing going on in the municipalities. 4 of the 6 municipalities was involved in municipal mergers, which took a lot of leadership, attention, and time. Also, of course, the COVID-19 pandemic also drew resources and management attention. And some experience a very high turnover of some employee groups, for instance, general practitioners. When it comes to implementation process factors, we saw some success factors. For instance, to have a stable and experienced implementation leader and team. And not the least, to have a close interaction or involvement of the coordination unit, which I talked about, which we have in Norway. And also involvement and specific measures from top management in the municipalities in defining roles, mandates, and expectations is very important. And of course, leaders at all levels must be involved and take an active lead, and not the least the leaders in non-health sectors, which perhaps doesn't think this is their piece of cake, you know? So, and also some municipalities used change agents and had very positive experience with that. And in the Norwegian context, to have a good structure and work approach for the coordinating unit is very important. Have a clear mandate and an interdisciplinary approach for their work. So to conclude, even though the Norwegian Directorate of Health played a facilitator role in the pilot, it took much more time than they thought, planned for, hence the extension for 2 years. It seems that the complexity of the intervention in terms of the variety of user groups, the service sectors involved, the need for system change was underestimated. Implementation of new guidelines, structures, and work approaches requires a thorough preparation and a good implementation plan, which often were not in place. And you need to have a continuous buy-in in all the organization. You know, if you're looking at the school, the kindergartens, labor market services, and all of the health services. So, and you know, leadership shifts, so you have to have a constant buy-in. And you have to have an understanding and commitment in the organization. So, employees and leaders' attitudes on the usefulness of the intervention and the understanding of how it differs from existing practice is really important. So to know, and the motivation for these care coordination guidelines was that research showed that too few people get an offer of an individual care plan. For instance, old people very seldom have an individual care plan. This doesn't mean they don't have coordination. They have, for instance, a primary contact, it's called in Norway, I don't know what it's called other places, but they don't get an offer of an individual care plan and a type of team follow-up. Also, for those who have a care plan and a team follow-up, for some of them, it didn't work as intended. It wasn't, you know, flexible or dynamic enough. It wasn't an active plan, you know. It was like put in a shelf. And a feeling of that it's too many people involved and the user voice is too, you know, it's not heard enough. So it's, you know, had to have better user person-centeredness and a more active individual care plan approach and working approach. So, thank you. Here I show pictures of my colleagues that had worked with me on this job.
Excellent, many thanks, and thanks for keeping the time so well. Any questions from the audience? There's some questions coming. I think that there is a question. Yeah. Okay. So the question that we have got is, where is the individual care plan and its follow-up in an electronic healthcare record, or is a healthcare record interoperable between care institutions, accessible by patient as well?
So the individual care plan is the patient's plan, and it could be on paper, it could be electronic. And the problem is that many municipalities think that if they don't have an electronic care plan, they don't have a care plan. But that's not, you know, the case. It could be on paper. But of course, there is systems for electronic care plans, which are accessible for from the user and all the other relevant persons. But it does not necessarily talk very well with the electronic journal, you know. So this is an issue. But I guess this is what we're working on in Norway and other countries in general, to have better communication between different systems at different levels as well. So,
Thanks for that. I think that we have another question over there. Yeah.
Lars Kaiser, University of Copenhagen. There's many municipalities in Norway, so I wonder whether it's due to very small number in each municipality and not enough experience that you have these findings. Have you any reflections or considerations about the number of people needing these care plans in each municipalities and whether they should work together in other ways?
So this is not for all in the use of nursing care or services. So this is a very few people, but still the research shows that it's even fewer than expected that gets individual care plan. So this is not for all. This is not so this is a topic they also had worked a lot with in the first 3 years. Who is to get who is the target group? For instance, typically for the elderly, do they need an individual care plan? Do they need this type of follow-up? And especially if they have an electronic, this is a discussion, do they have the resources and capacity to do this type of active follow-up in their own care plan? So I think they say in the documents, they say 3 to 5% of the population with the most comprehensive and complex needs. So, but I don't have an exact number for the target group. Okay. I hope I answered your question.
Did I answer your question? No, not really. Yeah.
Yeah, so what I asked about was, it is a very limited number and it requires experience, and with a small number of people in each municipalities, do you think or do you have evidence that maybe the organization is too small to actually be experienced enough to handle these patients?
But this is, I think this, sometimes you don't have the necessary stuff to have a good care team. That's a problem. But one important part of the pilot is to give necessary support and training for the care coordinators. That's one of the key elements in the pilot, is to support the care coordinators. Because that could be a nurse, that could be a teacher, that could be someone in the kindergarten, ideally. So, but for specialties, of course, the Norwegian municipalities, some of them are very small and doesn't have like a full spectrum of services available. And also one of the aspects which some of the municipalities has worked with is to make an overview of the available services, because the municipal employee they don't know themselves, what is available in my community, in my municipality. So this is also part of the pilot, getting to know your organization. Okay?
Perhaps you can follow the discussion later because we need to move on, but perhaps you should take advantage in the breakout because I can perceive some details that perhaps need a better and more detailed answer in your question. Yeah, thanks for that in any case. So we are moving to a totally different topic now. Our third speaker comes from the Durban University of Technology in South Africa. She is Busisiwe Nkosi, and I'm not sure whether I have pronounced that, so sorry about that. And the title of her paper is Critical Issues Detrimental to a Cooperative Cancer Treatment, Perspectives of Radiation Oncologists and Raditional Health Practitioners in KwaZulu-Natal in South Africa, which I think must be a region in South Africa or a place in South Africa. You can explain it later. So you have to press this button to move on, right? And so this the big one, yes. This one, yeah. You will move the slides.
Okay. Good morning, everyone. My topic is critical issues detrimental to a cooperative cancer treatment, perspectives of radiation oncologists and traditional health practitioners in KwaZulu-Natal province, South Africa. I would like to first define the word cooperative. The word cooperative means two disciplines where practitioners have agreed to cooperate or to work together towards treatment of cancer. And in this perspective, we are referring to traditional medicine doctors, which will later be referred to traditional health practitioners and will be abbreviated as THPs. On the other hand, radiation oncologists are doctors at the hospitals who use radiation to treat patients with cancer. The outline of my topic is introduction, methods, results, conclusion, acknowledgements, and references. The use of traditional medicine for cancer treatment is escalating globally. In the developing countries, 70 to 95% in the countries such as Ethiopia, Burundi, South Africa, Mali, Rwanda, Benin, and Ghana depend on traditional medicine to treat cancer. A framework was developed previously whereby they identified the elements of collaboration, enablers for successful collaboration, teamwork, and several action items that policymakers can apply within their local health systems. Although the radiation oncologists acknowledge the importance of cooperation between them and the traditional healers in order to improve the treatment outcome, but would not support the cross-referral. And there's no study that was done to understand why they don't want to refer patients to THPs. The aim of this study was to explore the ROs and THPs' views and thoughts on critical issues that are detrimental to a cooperative practice in cancer treatment in KwaZulu-Natal province, South Africa. The main research question is, what critical factors are detrimental to a cooperative cancer treatment between ROs and THPs? The methodology, we used exploratory descriptive qualitative approach. And as I said, the study was done in South Africa, in KZN, which has 11 districts, a population of 11, just above 11 million. And there are only 3 public oncology hospitals in the entire province, whereby the 2 public oncology hospitals are in the big city, and there's one about 90 kilometers away from the other 2. And in these hospitals, in the ones that are in the big city, 4 radiation oncologists rotate between the 2 hospitals. And in the other hospital that's 90 kilometers away, there are only 3 radiation oncologists. And with regards to THPs, at the time of the study, there were about 14,941 active THPs. And with regard to sampling, in order to sample the THPs, because I did not know them, the researcher used a snowball to sample them. And of course, the purposive sampling was used to select the radiation oncologists. And data was collected using focus group interviews for for THPs and individual interviews for radiation oncologists. And the THPs were interviewed in isiZulu, which is a common language spoken in KwaZulu-Natal, and the ROs were interviewed using English. The interviewed data was transcribed verbatim before data analysis, and TESH method of data analysis was used to identify themes. Of the 7 ROs that that were there, only 4 of them agreed to participate in the study, and there were 3 males and 1 female. And the THPs, 28 of them were involved or have participated in the study, and data was collected until data saturation. With regards to the THPs, only 3 of the 28 did not have formal education. Their education ranged from primary to a diploma. And their work experience was up to 60 years, so that shows that some of them were very old. The main themes that emanated from the research were 4. The first one was ROs undermine THPs practices. And I've included the quotes there, whereby the ROs are saying there is no way that THPs can be integrated, can work with them because they don't have evidence-based practice. And the second theme is ROs undermine THPs because they are uneducated. That refers to them not being educated about cancer itself, not education as in going to school, but not being educated about cancer. The third is the delay in the referral of patients. ROs are willing to work with them, but if they refer patients when they are advanced, when they don't know what to do, meaning the THPs, then it means the ROs are saying we will not then cooperate with them. The fourth, I don't know how to, okay, to take it back. Yes, the fourth theme is no communication about treatment details. What the ROs are saying is that THPs would just send patients to them for them to treat, but they don't know what treatment those patients had. And in that way, they won't be able to work with them because they won't know what to manage in those patients, whether the patients had various previous treatment that requires, maybe the patients are referred to them because they have advanced disease. Conclusion, although both ROs and THPs have shown willingness to cooperate, the concerns raised by ROs are detrimental to an effective cooperation in cancer treatment and should thus be addressed for effective patient care. The evidence-based practice and no education in cancer are the main issues preventing the cooperative cancer treatment between the THPs and the ROs. I would like to thank you all for listening, and I would also like to thank the ROs who agreed to participate in the study, as well as the THPs who participated in the study. These are my details. Thank you. Can I sit?
No, you should stay here. Thanks a lot. It was really, really interesting and totally new, at least for me, because I have never heard about any study looking specifically to this traditional medicine and collaboration with other, more academic health professionals. Is there any question from the audience? No? I think that we have some questions posed virtually.
How does this care coordination program align with hospital care existing multiple?
We need to read it aloud. Yeah.
Okay.
Hi, Albert. I'm your assistant.
Oh,
Here
sorry.
to help you throughout your day. Here are some things you can try saying.
Sorry about that, my fault. There is a question asking, how does this care coordination program align with hospital care consisting of multiple specialists? That is,
Okay. Sorry, repeat the question again.
Oh,
She disturbed me a little.
how this approach basically aligns with hospital care, where you have multiple specialists? That is
Okay. All right. At the hospitals, we do have multidisciplinary approach, but that is between the surgeons, the oncologists, the dietitian and other people. Those are integrated system. But when we refer to this cooperative treatment, we are now referring to the THPs coming from traditional medicine, whereby they have not yet been integrated into the national health system. But the other groups have already been integrated into the national health system. But now mentioning the ROs, it's because the ROs are the main people or professionals responsible for the treatment of cancer, and they integrate with other professionals within the hospital, but they are the main people responsible for the treatment of cancer. Hence, they are the ones that are supposed to cooperate with traditional healers in order to treat the patient with cancer. I don't know if I've responded to the question properly.
Well, I cannot say it because it was virtually, but to me it was clear. We have another one, so it says...
Elaborate on the perspectives of the THPs.
Yeah.
Okay,
So
yes,
the question is if she's invited to elaborate on the perspective of traditional health practitioners. Right?
Okay, I put that under the conclusion. The perspectives of traditional health, the THPs, they are more than willing to even do it like today, to start cooperating. Although in the framework that I've developed, they also have their own negatives towards the treatment of ROs, but they are more than willing to cooperate as soon as possible in order for them to work together with the ROs to treat patients with cancer.
Very good. And I have a question for you, a very short one.
Sure.
Your study didn't mention patients. Do you have any idea about how this possible collaboration can be received by the patients?
I have not mentioned that, but for the fact that in any developing countries, in my introduction, I've shown that 70 to 95% of patients are using traditional medicine, but they do not disclose that to the hospital. But evidence has showed that so many people use traditional medicine for the treatment of cancer and any other ailments.
Thank you very much. Thanks for keeping so well the time. So we need to move to our next speaker. You can take the seat.
So much.
So our next speaker, something with you. Our next speaker is Tinne Smets, right? She's assistant professor and senior researcher at the Vrije University here in Brussels, and her paper is about EU Navigate, developing a European navigation intervention for all the people with cancer and their family caregivers. The context, if I understood it well, is patient and family navigation intervention focusing on reaching undeserved individuals, right? The floor is yours. You have to press this button to move. The green one, right? Okay.
Thank you for the introduction. So my name is Tinne Smets. I'm a senior researcher and I work with the End-of-Life Care Research Group from Vrije Universiteit Brussel in Belgium. And I'm also a member of the coordination team of EU Navigate. EU Navigate is a European international research project funded by the European Union, in which we will develop, implement and evaluate a patient navigation intervention for older people with cancer and their families in Europe. So as you can see on this slide, there are a number of European countries involved in the project. We have Belgium, the Netherlands, Italy, Poland, Ireland, and Portugal. And we also have Canada as a partner, and I will tell you later why we have Canada as a partner in a European project. But first, what are the challenges that we would like to address with our project? So most people who have cancer are older people, and this affects millions of Europeans yearly. I think we also know that cancer care is highly fragmented and very complex and difficult to navigate for patients and family carers. Patients and families report significant problems in obtaining information and identifying and accessing social support services. We also know that access to palliative care is more limited for older people than for younger people. They receive less often palliative care, and when they do receive palliative care, they often receive it later in the care trajectory. Access to health and social support is also more difficult for people living in vulnerable situations. For instance, people who live in remote rural areas. For instance, in Poland, there are a lot of people who live very remotely. Also, people with lower socioeconomic status have more difficult access to health and social care. While cancer care in Europe is highly advanced in achieving cure and prolonging people's lives, it still has a limited focus on the psychological, social, existential, and practical needs of patients and families. And we think current cancer care services also insufficiently address the needs of family carers who fulfill essential care tasks, such as providing practical and emotional help, helping patients navigating health and social care, but their own needs and their needs for supporting patients are often neglected. And we think that patient navigation may offer a solution to meet the diverse and complex needs of older people with cancer and their families that are currently not sufficiently addressed. So in our project, EU Navigate, we aim to adapt a Canadian patient navigation program for use in different healthcare systems and countries in Europe. We will evaluate its effects on patients' quality of life and their social support. We will also look at cost effectiveness. We will study the implementation of the program in the different countries. And finally, we hope to deliver a new evidence-based EU navigation model for older people with cancer and their families, and recommendations for implementation of the program in different countries and healthcare systems in Europe. So most of the evidence for patient navigation comes from the US and Canada. So we first studied different existing navigation programs, and most of the programs focus on prevention and early detection and screening of cancer. And there are only a few existing navigation programs that look further down the trajectory at palliative and supportive care needs of people. So we found a very interesting navigation program in Canada, and that's why Canada is a partner in the project. This program is called NavCare. NavCare is a patient and family navigation intervention developed by Professor Spacehut and Duggleby in Canada. It was developed over the past 15 years for older adults with a variety of chronic illnesses and for people living with advanced cancer in rural areas of Canada. At this moment, the NavCare program has been widely implemented throughout Canada, but also internationally. And it is this navigation program that we will adapt for Europe. And I brought a short video about the NavCare program so you have a better idea of what the program entails. Let's see if it works. Yes.
NavCare is an evidence-based program developed over years of research. It helps people who live in the community with declining health. In this video, we're going to tell you that story. Our research began with a look at what it's like to need palliative care in a rural area. This early research showed that there were many gaps in support for people living with declining health and their caregivers. It also showed how communities would rally around these individuals, going above and beyond to help them with their needs. We also learned that there were many resources in rural communities that few people knew about, so people weren't using what was already there. Finally, we found that even though there were many skilled volunteers available, they weren't always connected to the people who could benefit from their services. NavCare was created to connect the dots between people needing support, community members able to give support, and community resources. Community members involved in our research told us that one of the best ways we could help them was to have a community navigator. So we did two things. First, we developed competencies and training for rural navigators with the help of international experts. These navigators learned 5 main competencies: addressing quality of life, finding resources, advocating for clients and families, facilitating community connections, and promoting active engagement. Next, we tested a nurse navigator and a nurse volunteer navigation partnership service in several rural communities. These pilot studies were successful. Volunteers enjoyed their role and found it meaningful. Clients and families felt that it improved their quality of life. As one participant said, "You may not be able to cure my illness, but you can sure make it more livable." We were on to something. But how might NavCare work in different contexts? What might the problems be? What might the impact on clients, families, and volunteers be? Those were the questions we wanted to answer next. Over the next few years, we helped 23 urban and rural communities across Canada start their own NavCare program. We learned a great deal about what makes NavCare successful and sustainable. We heard many wonderful stories, and some of those stories can be found on our website. Using everything we've learned, we are now scaling out NavCare both nationally and internationally.
So we are now in the first year of the project, and in this first year we are going to translate and adapt this NavCare Canada program to fit the healthcare contexts of the participating European countries. And to do that, we are using the ADAPT guidance developed by Graham Moore and colleagues. These are guidelines for adapting interventions, existing interventions to new contexts. The translation and the adaptations will be done in each country separately, together with local stakeholders in local adaptation teams. And these local adaptation teams, they are working together with an international adaptation oversight group in which the original developers of NavCare and we as a coordination team work together to advise the local adaptation teams and to check whether their proposed adaptations do not compromise the functional integrity of the program, so the core components. And once that is finished, we will perform first a very small scale pilot study with 5 patients and family caregivers. And then we will test this new program in a large international pragmatic fast track RCT. So that will start hopefully in November, and in this RCT we will compare the NavCare EU program with care as usual, and we will see if it is effective in improving patients' quality of life, their social support. We will also look at other patient, family, and navigator outcomes. We will study cost effectiveness, also effects in different subgroups, for instance, people living in remote areas, people with lower socioeconomic status. And we will do a thorough process evaluation of the implementation using implementation science frameworks. So this is just a slide with an overview of the design of the study. I won't go into detail about the fast track design. If you're interested to know more about the design, you can talk with me after the session, during lunch maybe. But this slide gives you an overview of the eligibility criteria. So who are we looking to include in the study? We aim to include older people, people who are 70 years or older with cancer and declining or worsening health, who live at home, and a family caregiver, if they have one, will also be included in the study. And we will do targeted efforts to recruit also those vulnerable populations, and to do that, we build relationships with local stakeholders who have connections in different groups of people. And then finally, to end my presentation, I would like to mention that active dissemination and stakeholder engagement is very important for the project, not just at the end of the project, but throughout the whole project. And that is why we work together with 3 dissemination partners who are also consortium members. We have European Cancer Organization, the European Association for Palliative Care, and Age Platform Europe. These are influential European umbrella organizations that together connect with a very diverse network of member organizations and other stakeholders covering domains not only of cancer care, but also aging and palliative care. And they also reach different target groups at national, regional, international, and European level. If you would like to stay informed about the project results, we have only just started, but you can follow us on the website, eunavigate.com, or via the Twitter account. And you can also subscribe to the newsletter of the project if you would like to stay informed. Thank you.
So thanks a lot for the presentation. Any question from the audience? Yeah, if there is a question just at the very rear. Oh, over there. Oh, yes, at the very rear. So sorry.
Thank you very much for your presentation. I just wanted to ask about the infrastructure that you've used for the local adaptation teams. Who are they in each of the different countries?
I think we are working together with universities, and they all have their own networks locally. So they recruit stakeholders that they think are very important to be in this local adaptation teams. For instance, people working in palliative care. In Flanders, we work with people from the palliative care networks. We have patient organizations. I think the European Cancer Organization helps facilitate connections with patient representatives, for sure. Yeah. And other local stakeholders, I think social organizations, local community organizations. But I think it's very different in all the countries, and I don't know the exact details of the composition of the teams.
Thank you. Is there any other question? Yeah, there's one question coming. Yeah, if you can ask it.
Why did you limit it to palliative care and cancer patients?
Yeah, we are a research group, of course, studying end-of-life care and palliative care, and we focus on cancer patients. It's a bit of a pragmatic reason, I think, because the European call was focused on cancer, but I'm sure this program is useful and applicable for much more patient groups. I think the original NAV care intervention was developed for older people with diverse chronic illnesses, so I'm sure it can also benefit other patient groups. But we will first study it in cancer. We're also looking in another project to develop a similar navigation program for people with dementia and their family caregivers. And we focus on palliative care also because there's still a large gap in navigation interventions for people with supportive and palliative care needs, because most existing programs focus on the early stages of disease, on screening, and early detection.
Thank you.
Thank you.
Thanks again. We need to move on to our next speaker because time is running. So our next speaker is Heidrun Sturm. She's head of innovative care structures in the Institute of General Practice and Interprofessional Care, University Hospital of Tübingen, right? And her paper is about InCept, patients' perception of primary healthcare provision with respect to access, continuity, and coordination, international qualitative perspective. So the floor is yours. That's the button. The green.
Okay. Yeah, thank you, Alfonso, and I'm very pleased to present this study, which is a stark contrast to the implementation studies which had been presented just before, because this was a really small pilot study thought to trigger international cooperation, and the topic was to look at patients' perception in an international context. Myself, shortly, I'm a physician and a senior researcher at the Institute of General Practice at the University in Tübingen, as I said. So the background, what is the context? Why did we focus on this topic? We realized that healthcare systems are reformed everywhere due to the same kind of challenges. We all have a lack of providers due to demographic change, and we have also due to demographic change increasing needs and coordinative needs. And so similar structures are introduced in different settings and countries, but we don't know really what is the effect or how do patients perceive these new structures. And that's what is missing. The patient perspective is often lacking. And if it is assessed, then very often, mostly it's in quantitative ways. So there are questionnaires used, and we feel that it would be really important to understand in a qualitative manner how patients perceive the new elements of care. And the second goal was also to see whether it is kind of the structural elements which are relevant to patients no matter where they are. So that's why we also used the international approach to look at the perception of patients in different settings, but with similar care structures and processes. But before doing that, we had to face a couple methodological challenges because we realized that qualitative research in an international context is not as easy as you think when you think about the study question. So first of all, we had to figure out how we can make the target group, so the patients, comparable, so that we look at the same kind of problems. How we can take different settings into account, if we have to take them into account in the first place. And then, of course, how we work with qualitative interviews with different languages. And I'm going to show you a little bit how we tackled that. Defining the care elements in the first place, what we would like to focus upon was we looked to different frameworks of the WHO, how to rate healthcare systems and so on. And in the end, we used the framework of Kringos, who is defining primary care elements or strength of primary care criteria. And those are divided into structure, into process, and into outcome elements. And for our purposes, we felt that we wanted to look at the process criteria, because this is what patients experience directly while they are cared for. So we wanted to focus on questions of access to their care, of continuity of care, coordination of care, and comprehensiveness. And so basically access what was also focusing on whether there is a gatekeeping system defining which provider patients can access, continuity, whether there are care teams, interprofessional cooperation, and then other aspects of coordination of care. So how did we tackle the question of similar patients? There we came across the concept of tracer conditions, which was already described by Kessner in the 70s, but it felt very helpful for us to look at criteria. In the first place, we wanted to have fulfilled, and the criteria we wanted to have fulfilled was that the disease had to have a functional impact, so that patients really felt that they need to have care. It needed to be a defined entity which is easy to diagnose. It had to have a relevant prevalence, because otherwise it would have been difficult to find patients to look at. And of course, along with the functional impact, it also should have the necessity to have contacts to the care system, because otherwise we cannot look at the experience with the healthcare system. And in the end, it should have an impact on, our factors like access, continuity, and coordination should be relevant for the care of these diagnoses. And so we had several options we were thinking about. It was diabetes, it was back pain, it was some kind of heart condition or stroke, and we discussed that with colleagues from the international team who are with GPs and nurses and healthcare services researchers, and then in the end we came up with a combination of an acute event, which could be either myocardial infarction or a stroke, so that the patient has really an acute need to seek care, and an underlying chronic condition, so that also prevention and long-term care is relevant to them. And so we said that as a chronic underlying condition, these patients should have had metabolic syndrome, which is a risk factor to both acute events. So that was the inclusion criteria. And then here are the partners we were working with and where the data was collected. We worked with Linköping University in Sweden. We worked with the UK, and that was in Jersey, which is a little bit of a different structure than the NHS. We worked with Switzerland, Fribourg, and then we had a very close contact to Brazil, the Fluminense University, in close to Rio. And so our partners then interviewed few patients. It was, as we said, kind of a seeding study. In Sweden, it was 7 patients with the same indication. In Germany, in Tübingen, it was 10, Switzerland 7, Brazil 10, and so that was the number of interviews. As we said, the tracer condition was the inclusion criteria, and then we had semi-structured interviews. We used the critical incident technique, which means that the patients they started with the acute event, and from there they developed their record or their memories about their experiences with care in relation to access, continuity, and coordination. And those interviews were led by the local partners in the local language, obviously. And then the question was, how are we going to analyze it? So we used, or the goal was to use structured content analysis. And then after a long discussions in the team, we figured out that it would be best if the analysis is, in the first step, performed in the local language, and then also that we come up with a category system in a local language, and then we merged those category systems. And then the whole interviews were not translated, only the citations we needed to kind of fill the category system. So what were the results? For the categories, we used an inductive and deductive combination of approach, which is commonly used. So we had as main categories our goal structures, access, coordination, continuity of care, and patient-centeredness as a last one. And then the subcategories and smaller categories, which I didn't include here, were inductively developed. And so for access, it was financial barriers and geographical accessibilities, which were topics coming up in all the countries. Then for coordination of care, it was the existence of a coordinator or case manager, whether there was a gatekeeping system or the GP was acting as a gatekeeper, and then interprofessional cooperation. Continuity of care, there were 2 aspects. One was in the healthcare professionals on the one hand, and then informational continuity, on the second. And patient-centeredness, responsiveness, maintaining information flow, and patient-centered behavior. So then only a few examples in continuity of care. The communication was a key. We have one subcategory was feeling seen and heard, and that was independent of the country. Patients said in Sweden, well, that we can talk about things and how I'm feeling, and sure, she wants to help me in all that all the time, because I had a bit of trouble afterwards. So that was referring to a cardiac care nurse. So it was relevant that there was a personal relationship. And the same in Switzerland. Yes, the closest was always the advanced practice nurse who talked openly with me. And on the other hand, there was the content information flow, where one patient in Germany said, I was discharged from the hospital, no one told me what I should or should not do, or what I should keep away from, and so on. So those two levels, the emotional or feeling seen and heard, and maintaining the information flow. And this is kind of a summary slide where we try to come up with the main consequences. So in the first place, positive and negative experiences came from one country. Like in Germany again, and this, the cardiologist, was the first person who could explain this to me in simple terms. And then on the other side, there was a patient who said, so I poked around in the internet until I found something and nobody was there to explain anything. So it was not country focused. Second was the local situation is reflected in expectations, and of course also the expectations are shaped by the local situation. For instance, in Brazil, they said, we didn't have a reaction to the referral, it's complete negligence. And that was, from Brazil, we had a lot of answers that there was no access, not enough resources, and therefore patients felt neglected. In Jersey, but you know, you got to wait anyways, or on the right-hand side, it's a joke, you know, after all, you're paying. And in Germany, already I was in rehab twice, and I was dissatisfied each time. So high expectations, and then dissatisfaction. And the last, that we really could cluster the patient experiences around processes, and that was not related to the country again. So in Sweden, they said, so the heart failure nurse know exactly what to ask and so on, how I feel. So that's again about the care coordinator or the nurse there. In Germany, they said, no, in Jersey, next, can I point? Actually, I'm not sure. No, oops. In Jersey, so who guides you through the system? And the interview said, well, Brenda, my partner. And in Brazil, they said, we didn't have a reaction to the referral, so we were neglected. Oh no, that was the wrong one. It's hard for me to read here. And in Germany, yes, if it's related to the disease, it's only the GP. And in Switzerland, the same. With the GP, one has a very personal relationship. So it showed that from different countries, patients' experiences could be grouped around processes. And then in the end, we can say there are similar categories and they're not clustered along countries, but of course they're shaped by patients' interviews and probably by the processes and structures underlying. And we're trying now to put the content in these categories. I'm not going to elaborate on that, but to conclude, we can say patients focus a lot on relational aspects of care in all the settings. And it is distinct aspects of care provision rather than the function or the structure itself that are important to patients. So it's not important whether there is a gatekeeper or not, but it's important that there is a person they can relate to or whether there is access to the care they need. Patients' perceptions of care processes can provide information about their preferences. So we conclude that it's important to really include patients' preferences also when planning new care structures. And therefore, I thank our team from the different places, and if you are interested in more information, don't hesitate to contact me. Thank you.
Okay, I'm just only going to allow one question this time because we are running short of time. Is there any question from the audience? Neve. Sorry, there is the same lady, at the rear of the... No, the same lady, back to the rear. No questions.
Thank you. Thank you so much for your presentation. I was wondering, did any of the care that patients were giving their perspectives about involve home-based care?
Sorry, I didn't understand it. Can you say it again?
Was any of the care delivered by the teams based in the people's own homes?
Was any of the care delivered by people?
In their home.
In their home?
Home care.
In Brazil, that was the case, not in the other European countries. There, the patients were always picked up at the place of care provision, so either the GP practice or primary care center.
Okay,
yeah.
Thank you.
Thanks again, and apologies for being so quick. So let's move to our last but not least speaker. It will be presented by two different people. So first person is Mrs. Diamela Vicencio, Project Coordinator, ASBL, and her paper is about case management as a tool for integrated care. So Diamela, the floor is yours. You have to press this button. Sorry, I didn't get his name.
Diamela en Nicolas Mancier de Retinam. Dus,
Si ça ne dérange pas, je vais faire en français. Et j'ai promis à mes collègues de Courtrai que l'année prochaine, je ferai la présentation en néerlandais, voire en anglais. Voilà. Donc je vais prendre des cours cette année. On va essayer de trouver la solution. Donc moi, Nicolas, Diamela, on représente les initiatives de soins intégrés qui se trouvent en Wallonie. Il y en a également à Bruxelles et en Flandre. Et donc, c'est des initiatives qui, à la base, ont été mises en place en 2018 pour nous dans la région de Namur et Diamela de Liège. Et à la base, donc, c'était des projets pilotes qui faisaient partie d'un plan global comprenant 12 initiatives de soins intégrés. Et ils visaient à favoriser une meilleure intégration des soins autour des citoyens. Depuis 2023, maintenant, nous sommes plutôt des partenariats de soins intégrés. Donc, à la base, on était projet pilote. On testait des initiatives de santé intégrée auprès de la population. Et maintenant, on dégage des best practices qu'on essaie de rendre pérennes pour la suite. Et à savoir, donc, il y a un plan interfédéral qui va arriver. Et donc, il y aura une suite au niveau des soins intégrés. Donc, la spécificité des partenariats de soins intégrés, c'est d'avoir beaucoup de partenaires, donc diverses organisations, institutions. Donc on peut relever les hôpitaux, les médecins généralistes, les pharmaciens, les infirmières à domicile, les pouvoirs locaux, donc la commune, la province, et bien d'autres encore, les mutuelles aussi, qui sont partie prenante de ces projets. Et donc ces partenaires jouent un rôle crucial. Donc nous, on est un organisme de mise en réseau, et eux proposent des initiatives et contribuent aux objectifs du projet en favorisant notamment la coordination de la santé sur le territoire et notamment aussi en améliorant la communication entre les prestataires de soins de santé.
The main objective of Resinam and Chronicopol is to address the specific needs of chronic individuals by integrating different aspects of care. They include medication management, considering social determinants of health, and improving the management of mental health issues and social insecurity. By focusing on holistic care approach, the projects aim to enhance the quality of care, health outcomes, and the overall patient experience. Improving coordination and communication among healthcare provides a key goal of Resinam and Chronicopol. This approach helps avoid service duplication, ensures continuous and consistent care, and facilitates patient follow-up. Integrated care initiatives also emphasize the importance of addressing social determinants of health, such as housing, education, and employment, which can have a significant impact on individuals' health.
Donc, au niveau du type de population, nos projets, en 2018 jusqu'en 2022, c'était les publics polyfragilisés, Hein. Donc on entend polyfragilisé, c'est des problématiques au niveau des soins, mais également ça peut être des problématiques psychiatriques et des problématiques de précarité sociale. Donc c'était quelque chose de très global. Et donc nos publics cibles incluaient différentes dimensions qui étaient amenées à communiquer entre elles. Maintenant, depuis 2023, nous avons la population au sens large. Et donc c'est déjà maintenant. Ouais.
This Chronicle and Resinam had a mission, is to visualize issues for reflection and engage in active, participative and innovative research to analyze and adjust integrated care practice. For example, in the specific focus area of transgender support, Chronicle Poll examines various aspects. Firstly, it explores the type of support provided. What kind of support is offered to transgender individuals? Secondly, Chronicle Poll assesses suitability. Is the support adapted to meet individual needs? Lastly, investigate the impact of language. Who does language influence to the support provided? Through this reflective and research-driven approach, Chronicle Polls and Resinam aims to continuously improve integrated care practice to better meet the needs of the transgender community.
Donc, l'action Case Manager est une action historique à Resinam, et donc au départ de la théorie, de ce qui était écrit dans les livres, on a implémenté la fonction sur le territoire de Namur, et le premier travail a été de travailler avec l'université et les coordinations de soins à domicile. Et donc c'est vraiment une spécificité du Case Manager de s'adapter sur le territoire sur lequel il se trouve. Et donc on a eu un groupe de travail pendant 2 ans où on a essayé de déjà faire un effort de distinction par rapport à la fonction de coordination de soins à domicile et voir comment le case manager pouvait développer ses spécificités et agir en complémentarité avec les coordinations de soins à domicile notamment. Alors, la spécificité du case manager, en tout cas, c'est d'intervenir quand le prestataire va au-delà de ses missions. Ça, c'est vraiment la phrase qui ressort. Donc, l'équipe de case manager sous Resinam travaillait vraiment avec les différentes dimensions des publics polyfragilisés. Et l'idée, c'était de se dire que dans la dimension médicale, par exemple, ils n'ont pas toujours le même langage que dans le champ de l'action sociale ou dans le champ de la santé mentale. Et donc, le case manager s'assurait un peu que la communication soit fluide entre les différents secteurs. Et on partait aussi du constat que le patient, par rapport aux différentes initiatives qu'il y avait sur le territoire, avait des fois un peu du mal, des difficultés à s'y retrouver. Et donc, au niveau de la plus-value pour les patients, j'en viens au slide ici, c'est vraiment de pouvoir activer les initiatives en fonction des besoins du patient. Et donc, il y a vraiment ce travail du case manager qui va au domicile, qui suit la personne, qui essaie de comprendre son parcours de soins, d'émettre les priorités et de voir quelle initiative pourrait répondre aux besoins de la personne. Et donc, le case manager doit vraiment bien connaître les réalités du territoire où il se trouve. Il y a également la concertation avec les patients, avec les prestataires et la personne. Et donc, c'est l'idée aussi de mettre en lien les différents intervenants et de pouvoir assurer l'établissement d'un parcours pour la personne, un projet. Et enfin, la collaboration, vraiment viser la collaboration entre les partenaires. Et donc, le case manager, une fois que le réseau est activé et fonctionne avec la personne, là, il se retire et peut réintervenir en fonction des besoins.
In conclusion, the Integrated Care Initiative, implemented by Wallonie model, have brought about significant improvement in the care and the well-being of chronic individuals. Through partnerships and holistic approach to care, these initiatives have succeeded in enhancing care coordination, addressing social determinants of health, optimizing medication management, and promoting better patient experience. Question? Thank you.
Oh, no.
So thanks a lot. Is there any question from the audience? No? I have... Pardon? Oh, yeah. Just at the risk of, keeping you a little bit for a couple of minutes, I just wanted to ask you a specific question. In terms of sustainability or transferability of your approach, how do you see, imagine bigger regions in France or in Belgium, how do you see your approach working? So sorry.
Pardon?
So the idea is how you can expand your initiative to other places. Well, if not, we can perhaps. Never mind. Then the session will be over. Let's then move to our lunch break. Thanks again to all the people that have been here till the end, and thanks to all the speakers. Thanks a lot to all of you. Thanks.